Thank you, Dr. Berter, for this inspiring lecture. It's also my great pleasure to introduce our next speaker, Dr. Stine Kristensen. Dr. Kristensen is the head of the Laboratory for Reproductive Biology at Higgs Hospital, University of Copenhagen, Denmark. And we'll talk about the future of oncofertility. Welcome again, Dr. Stine.
Fantastic. Thank you so much, Aline. Thank you. So, hello everyone. It's good to be back. So, thank you so much for this fantastic title, Alina and Mauricio. I think it really gives me the option to go into all the very interesting aspects in this oncofertility field at the moment, and it's a dangerous door to open unless you have 4 hours, but I'll try and keep it within the 20 minutes. So with that. So fertility treatment or fertility matters for these young cancer patients. It really does. It's really almost as important as surviving the cancer for some of these patients. And we are getting a lot better to treat cancer, but that also means that we have a lot of these cancer survivors. And they are very interested in the fertility because it's a matter of quality after life. And having your own children is of higher quality to these patients. So we know that they want information, and we have made these fantastic guidelines. Both the ASIM and the ESRA has made big guidelines that we could follow. And we know that providing the patients with this information is really important. It affects them very positively, and it reduces the long-term regret and reduces concern regarding fertility. So that is very important. Unfortunately, we have these wonderful guidelines, but they're very difficult to actually fulfill because this setting is very resource demanding, and when we look into the literature, it just varies a lot between centers and country, how they're actually able to accommodate to these recommendations. So as you can see here, it's not optimal. It varies between 26% to 95% how the centers actually fulfill these recommendations. And when you look at the referral process, then it's also very variable from 10% to 67%. So it's not all the patients who actually get this option for oncofertility and to preserve their fertility. So what are the barriers? So there's been multiple studies where they have asked the physicians, and it's very much a lack of time, knowledge, and resources. It's also the thing that these patients need to go into immediate cancer treatment. But we can actually overcome this with ovarian tissue cryopreservation, as I'll talk to you about in a minute. There's also this perception that there's poor results with using these fertility-preserving strategies. I also will address this later. I don't think they are very poor. I think they're actually quite good, and we're giving these patients a fair chance. Then there's also the poor prognosis patients. They're difficult. And then the patient characteristics with the age and the parity. And that's very relevant because we know that some of these techniques are not very effective in older patients. When you're above 35, you just have a very limited ovarian reserve, and then these techniques are not very efficient. So age is definitely a factor. So a lot of these studies has been made in countries where it costs. The financial aspects is a big point because it costs money to actually have these procedures. In Netherlands and Denmark, we're actually lucky. This is reimbursed by the state, so we can offer this to all our patients, which of course then is a little bit different with the barriers. But still, when we look into the Dutch studies, it's still kind of the same things that are barriers to these techniques. And when you look at the patient level, some of them, they actually just want to survive the cancer, so it's not a priority. But for most of them, we know it is. When we look at the professional level, then you can see again lack of awareness, knowledge, time, attitude. It's very difficult to put into these systems. And a lot of the oncologists, they just focus on the cancer. They completely forget the fertility. And at the organizational level, it also needs to put into the infrastructure that you can actually have these patients and talk both with the oncologist and the fertility department. And coordinating this is very difficult within many centers. And also agreeing on who has a responsibility to actually inform these patients about their fertility options. So in this Dutch paper, they also went into what can improve, what can we do to overcome these barriers. And A big point is actually just developing information, both some online aids or leaflets could be a big help in a lot of centers. Also educating the professionals is of course a big point to make them aware that they can actually offer this to patients and what patients to offer it to. And then again, having these specialized coordinating nurses and coordinators to the fertility department is also key to actually provide the patients with this treatment. So in Denmark, we're a very small country. We are only like 5.5 million people in the whole of Denmark, so that's very little to like your 12 million in one city. But with that setting, we have been able to make a very centralized service to Copenhagen. So we receive the tissue from 2 other big cities in Denmark, and then the tissue is transported to our local hospital. So we're just one center centralizing the whole service. And I think it's really key that we keep the high service on a few hands, because we have around 60 cases a year. So that's not a lot. And you need to be very specialized and have all the knowledge to actually consult these patients. So we do it in just one center, and when we need to transplant, we also take the tissue back to the center where the patients are. So I think it's a very patient-friendly approach, because they can stay in the hospital, get the cancer treatment, and then it's ovary, which is going back and forth. So we've done it in Denmark, and this is just examples of how you can also do it in larger countries. In Germany, they have combined a center with Germany with Austria and Switzerland, and they have 2 big cryobanks, and then they fly in the tissue from all the collaborating universities and hospitals. There's also the big oncofertility. I don't know if you can see it, but this is a whole American setting where they're actually able to have a big network and connecting a lot of centers worldwide. And this is where they exchange a lot of knowledge, not patients, but knowledge instead within this field. So there's different ways of doing it, but it is key to provide a very high service. And what this oncofertility also did recently, they sent out this survey to see how is it actually, how much are these techniques getting available and are they utilized in the different centers. And here you can see for breast cancer patients, egg freezing is used, and embryo freezing, and then ovarian tissue, but to a lesser degree. When we look at the blood-borne cancers, you can see again, this is sperm freezing, egg freezing, embryo freezing, and then testicular tissue freezing. So it is getting utilized in a lot of centers now, not to the 100%, so not optimally, but it's still getting provided to a lot of patients. And here you can see the children. We can only freeze the tissue. We cannot freeze the oocytes because they're not maturing these oocytes yet. So that's tissue freezing and oocyte freezing. So as you can see, it is getting provided. And you can see here a lot of countries are now involved in this network. So the big question is, are they then using the tissue? Now we're freezing the tissue for 20 years, but are they coming back and using it? And that's really disappointing, I have to say, because as you can see the numbers, 5 to 7%, that's not very impressive. It's both when we look at ovarian tissue and the oocyte, same with the sperm cryopreservation, they're not coming back for it. So that's been quite the trouble that we are kind of still anticipating why are they not coming back. And recently there was this very nice study, and as you can see, actually the top one is absent of a partner. So this was exactly the same as Michel DeVos said yesterday with the social freezing. Why are they not coming back for the oocytes? It's because they cannot find this guy. So it's definitely a matter of finding Mr. Right. He's just not there. I think if the whole male population of the world looked like that, we had overcome that problem, but they don't. So then that's a problem we need to solve, of course, but I can't do that. Someone else has to fix that. But as you can see, also on the list is just this pure desire to conceive spontaneously. That's of high priority. And also just having a desire to be pregnant is also one of the reasons that they don't have it. And then this pregnancy with spontaneous conceptions, we do see that's almost 14%. So this means that they're actually just getting the children they want without having to utilize this tissue they have cryopreserved. And that makes sense because that's a very recent study. This is called the POSITIVE trial. This is a big study with the breast cancer patients. They follow them and how is stimulation and going out of this hormonal treatment affecting them. And they just did this, it just came out this in May. And what they see, when they follow these patients, they go off the hormone treatment and then they see how many become pregnant. And as you can see, actually, out of all of these 497 women, 74% get pregnant, and 64% actually have a child. So it seems like they survive cancer, breast cancer, and they still have very good success rates in actually achieving to have a child. So it doesn't seem like the cancer treatment is that gonadotoxic. It's really not depriving them of their fertility. So I think that's one of the big reasons that a lot of them actually get the children they want, even though they have been through cancer treatment. So when we look into the Danish cohort, this is our numbers, and here you can see we also have like 1 in 5, they die, so of course they don't come back. We have 15% coming back for the tissue, 9% donate, and 60% still have the tissue in the bank. And you have to remember, a lot of our cohort is also children. And we've been doing it for 20 years, but they're still not reaching the age where they have a pregnancy wish. So we still have we have a long way to actually get the full picture of who is actually coming back, because some of them are very young still. And here it's a little busy table, but here I've just put in all the diagnoses that we have, different indications, and then we looked in only the patients who had survived and had a 5-year follow-up and were above the age of 24, so starting to think of maybe children. And when you look at all the rates that they come back, return for the tissue, it's actually quite comparable between the different indications. And you can see here it's a lot higher than the 5%. So they are coming back. It's a little busy, but you can just see it's not that different between different indications. So overall, 1 in 5 actually do come back. But how successful are they? So that's now the question. So okay, they come back, but are they actually getting the children they wish for? And when we look into the literature, when you look at the cancer patients who have come back to use their embryos, you can see there's these 3 studies. The live birth rates of around 45 and 31% in the biggest Swedish study. When we look into the oocytes, then that's very limited literature, and most of it is from EV in Spain. They have a big cohort they have published on multiple times, and a lot of these studies, as you can say, is just case reports. So it's difficult to calculate the success rate when the live birth rate is 100%. That's 1 out of 1, so that's fantastic, but not real numbers. So it's actually so it's a study you can't see, but there's an EV study in the bottom here, sorry about the chairs, but that's with Anna Kobo, and she had 80 cancer patients who came back, and there's a 31% live birth rate. When we look into the ovarian tissue, we did this systematic review recently because there's a lot of small cohort studies. And there was more than 500 patients included in this. And as you can see, the pregnancy rates, 37%, and live birth rates, 28%. And this is like centers all over the world. So it's a lot of smaller and larger cohort combined. And the last here, you can just see this is actually on the day of transplantation. They have a high FSH, and then 4 to 5 months later, then FSH go down, and they have their fertility or ovarian endocrine function restored and have the option to have children spontaneously. So I think that's very fantastic with ovarian tissue, and maybe I'm a bit biased because this is what I do every day. I freeze ovarian tissue, but we actually provide the patients with an option to go home and make the babies. We transplant tissue back, they get the endocrine function restored, and they can make babies naturally. And you can see here, this is the newest numbers from Denmark. And you can see that under the delivery rate, or the deliveries, like 40% was after ART, and then 60% was spontaneously. And this is actually representative for all the children born in the whole world, like 50-50. 50 natural and 50 ART. You can also see our rates. They're a little bit higher than what was shown in the systematic review. So here we have actually 41% live birth rate. So that's very impressive. So it's actually working quite well in some of these patients. Then the age thing, it's always a matter. We talk about it all the time. In this data, of course, age is also a factor. So the younger you were when you froze your tissue, the better chances you have of achieving a pregnancy afterwards. And this is the newest data from the German cohort, and you can just see live birth rate according to age. It goes down. It's the same with the oocyte freezings. So this is what we're up against, the age factor. We can't offer the women above 35 years of age very much with these technologies right now. And that's why we also need to improve them, and I'll show you there's room for improvement, so I do believe that we'll be able to do more for these women above 35, but it's going to take some time to optimize the procedures. So we can offer these techniques, and it seems pretty comparable with the success rates. So what to choose? Or just don't choose, because that's what Michel DeVos are doing in his group. They're not choosing one or the other. They are choosing actually to combine the different strategies to get most out of this ovarian tissue, because you have to act immediately when they're going into the cancer treatment. So here, and I think it's a very beautiful study, they're showing that in, can you see the bottom down here? Ah, okay. That's a pity. Okay, I'll have to, okay. So the way to the left, we have this stimulation, normal stimulation in the clinic. So some patients do that, a lot of the breast cancer patients. Then they have the group here, group down here. Then they actually perform what's called OPU IVM or in vivo IVM. So they actually extract the small antral follicles in the ovary, and then they perform IVM that Michelle will talk about in a minute. In the group where you have a lot of different colored bars, then they take out the ovary, but then they also collect immature oocytes from the ovary and cryopreserve them. So they have both the cortex and the immature oocytes from that ovary. In the next one here, they perform both the in vivo IVM on the one ovary, they take out the other ovary and do IVM on the other ovary also. So that's like combining 3 different techniques. And in the last group, they also perform ovarian stimulation on, they remove one ovary and perform ovarian stimulation on the other ovary. So this is really optimizing the fertility chances for each of these women. And they really have this personalized approach to each case, depending on their ovarian reserve, what can they offer these patients, and get the most out of these ovaries before they're going to go into cancer treatment. So I do think this is the future. We need to optimize whatever we can get out of these ovaries in the moment when we have these patients in the clinic. So the 2-for-1 concept, that's what we're calling when we have the ovary out anyway. Here you can see we have dissected the cortex up in the upper part of the picture. Then we have this medullary tissue left. And this is from these medullary tissue, we can collect the immature oocytes. You can see them down here. So we have both a lot of oocytes with big COCs, smaller COCs, naked oocytes, like it's a huge mix of different oocytes from small antral follicles, like 2 to 8 millimeters. So these are the ones that we would normally throw out, but now we're collecting them, and Michelle is doing it clinically. So you can collect them, perform IVM for 36 to 44 hours, and then you can collect the immature oocytes and vitrify them. So we're doing it for research in Denmark, trying to optimize these conditions, and a few centers is doing it clinically, and there's now 5 children born from collecting these oocytes from these ovaries in the lab and doing ex vivo IVM. So it's an add-on to doing the cryopreservation of the ovarian tissue. So regarding the transplantation, because in the ovarian tissue setting, the transplantation is really the difficult point, because this is where we lose a lot of follicles. And this is a map where you can see all the centers who are performing ovarian tissue transplantation and freezing. And when we look into the different approaches as to how we transplant, then they do it very differently. Some use stitching, some use interseed, they cover the tissue in the graft site. Some use pockets, peritoneal pockets. You can both put it in peritoneal pockets or in the ovary, like we do in Denmark. And you can also put it in abdominal pockets. So you can put it almost everywhere, and then this tissue will actually work. As soon as it gets some blood supply, then the follicles will reawake, and they will grow. But we don't have any data right now showing which approach is actually the most efficient. So that's kind of next step, because we can really improve this procedure if we get the grafting right. If we can secure more follicles surviving, then we can have much better success rates. So again, that's an area where we really need to go in and optimize. And this is just to show you, though, that when we transplant, it's actually a very small pool we transplant. So when you're 25, you have around 22% of your ovarian reserve left. Then we take out one ovary, That means we halven the pool. When they need the tissue back, we transplant half of that tissue back. Then we, again, half the follicular pool. And then 70 to 90% of the follicles die. That's a lot. And that's what I want to improve. But it means that in the end, the pool we're putting back corresponds to a woman who is 42 years of age. But you have to remember, these oocytes are 25 years old. So that's why it's still working quite good. But it just makes us, it's difficult to work with because you just have a very low ovarian reserve and it's difficult to stimulate these women. But that's a different talk. I don't have time to go into today. But we're trying a lot to improve the grafting, and there's different approaches. And again, that's another talk that I would love to give another day. This is where I use most of my time trying to optimize the grafting. Then a final note, if these women don't use the tissue, as you saw, a lot of them are not using this tissue for fertility. One idea is to use the tissue to actually endocrine function. We've done this in a few patients in Denmark, where they just have the tissue transplanted to actually get the hormones back, to get a natural cycle. The problem is that this tissue is not very effective. As you can see in these graphs, this is 2 examples of 2 patients where we have transplanted tissue, and you can see the FSH going up and down, up and down. So it's not giving a very consistent hormone or endocrine function. So it's really not a really good approach, but it's been proposed. So with that, I have a few slides left. I'll be done in a few seconds. So it's this whole development in cancer treatments. Right now, we are hearing a lot about the immunotherapies, and we're kind of saying, is this really the end of oncofertility? Because if it's not gonadotoxic anymore, then we don't need to freeze oocytes or ovarian tissue. So right now, the whole development of these immune therapies is what we are really anticipating to see how will this cohort look when some of these new strategies will take place. The only thing is that we don't really know if they're gonadotoxic. We don't think so, and preliminary data so far is not really showing any gonadotoxicity, but we're also calling for really good studies to actually aim to look at this, because there's not a lot of those right now. So Lambertini and Richard Anderson did this paper recently that we don't know. We can't know whether or not these immunotherapies will change the field or not. But that's looking into the future. Hopefully in 5 years, we'll know more. So with that, I will sum up. And really the take-home messages here is that we need to improve our oncofertility programs to give the patients the best treatment. We also need to provide them with these options, and especially the post-cancer follow-up, to actually make sure that we assess their fertility and help them family plan so they can utilize the tissue, because we don't really do that. We just take out the tissue and send them home. And so they'll take out the oocytes and send them home. So we need to follow up. Then we need to optimize combined treatments to optimize the fertility potential of these patients. We need to improve the efficiency of the techniques. And then we need to make big, large cohort studies actually showing the efficiency of these techniques. So I hope that really gave you a little look into the future of oncofertility. And you are very welcome to write me or drop by. If you're going to ESRA this year in Copenhagen, then please drop by in our lab. You're all very welcome. So with that, obrigada por ora. Thank you so much.